So next we have four very interesting speakers explaining the Renal Services Transformation Programme. And kicking it off is Lydia.
Hi, thank you. And thank you to this morning's speakers, some really interesting talks. And Hattie, I totally love Harry Potter and medals as well. So completely agree with you. So hi everyone, my name's Lydia Ball. I am the lead commissioner for the Renal Services Clinical Reference Group. I'm going to try and explain a little bit about what that means and also about some changes to commissioning that are currently taking place across England. I'm then going to pass over to some of my clinical colleagues who are listed on the screen there, so we can explain the various different work streams that are taking place across the Renal Transformation Programme in England at the moment. And I'm just figuring out how to work the clicker thing to make the slides move on, so please do bear with me. So in terms of the clinical reference group, just trying to get to the next slide, apologies. So apologies, I seem to have a bit of a delay with my slides. Would somebody be able to move the slide on for me? Would that be okay? Thank you very much. So what is a clinical reference group? I'm really conscious that in the world of commissioning, we talk about a clinical reference group, and actually, what does that mean? You know, I certainly didn't know what it means before I came into a sort of commissioning world. So essentially, it's a nationally based group that provides clinical advice and leadership on specialised healthcare services in England. And it's made up of expert clinicians, commissioners like myself, public health experts, and patients and public voice representatives. And what do we do? You know, what's the purpose of us? So we advise NHS England of the best way to provide specialised services. And what does that really mean? So it means that we essentially lead on the development of clinical commissioning policies, service specifications, and quality standards. And actually, what that essentially means is we produce the policies and the service specifications which define the standards of care that NHS trusts in England have to follow in order to be able to provide specialised services like renal replacement therapy and kidney transplantation. And I think the key thing to say from an NHS England, both a clinical reference group perspective, but also within the development of all of commissioning policy and service specification, the patient and public voice members are at the absolute heart of everything that we do. So within the clinical reference group itself, we have patient and public voice representatives sitting on that group. But within the development of the policies that we produce and the service specifications that we produce, there is always patient and public voice engagement. Next slide, please. So just trying to explain a little bit about what's going on with commissioning at the moment in England. It can be a little bit confusing, so I'm just going to try. My slides are a little bit busy, so I'm just going to try and pick out what I think are the really key points that hopefully make this a little bit clearer. So back in July this year, the new integrated care boards became statutory bodies. So there's 42 integrated care boards across England. And what we are doing as NHS England is we are delegating some of the specialised services that we currently commission to those integrated care boards to commission themselves regionally. So what does that mean? It means that there's no change to what's currently commissioned. So everything that we currently commission as NHS England in terms of specialised services, so for renal replacement therapy, for renal transplantation, there's no change to those services. And those services will still continue to be legally maintained by NHS England. We're just delegating the delivery of them and the responsibility of the delivery of them to the integrated care bodies. Now, the idea is that the some of the services will be delegated from April 2023, so that's obviously April next year. Some of the services will be delegated a little later, and some of the services are actually, it's for such specialised patients, they won't be delegated at all and they'll be retained by NHS England. And I'll come on to that in a moment. Next slide, please. So why are we doing all of this? What does it actually mean? What's the point? So we're doing this because we feel it will improve quality of patient care, equity of access for patients across this country, and it will improve value for money for the NHS and the taxpayer. So from a quality of care perspective, how is this going to improve that? You know, what difference is this going to make? And actually the purpose of pulling together commissioning at an integrated care board level, so at a regional level, that means we can join everything up. So the integrated care bodies for a particular region can join up patients' care, and they can look at a patient's care from a primary care level, so at a GP level, through to secondary care in the hospital, through to specialised care. And enabling them to do that will provide a more holistic, better access to care model for patients. It will provide a multidisciplinary approach, and it will increase focus and investment on preventative care. So as I say, being able to look at the commissioning of services and the money flows right across from GP level right through to specialised services. So it'll improve equity of access because the IC, the integrated care bodies, will be able to look at what are the needs of our population within this particular area. Do we have a high prevalence of kidney disease, for example? Do we need to put additional money into kidney disease, use this as an example, within our area? And do we need to think about how we really invest because we do have a high population of patients with the condition? In terms of equity of access, it will also provide integrated care services with the opportunity to try and level up access to services across the country. And as I say, NHS England will remain legally responsible for the delivery of services. So we will have processes in place where we're able to look at what service delivery looks like across the country. And if there were any issues, we'd be able to step in and try and support our trusts and integrated care body colleagues to resolve those. And finally, we think it'll improve value for money across the NHS. So we think it could, by investing in preventative care at the GP level, we think that could reduce demand for specialised services, and specialised services are very expensive, as I'm sure you can imagine. So by actually identifying patients in a community setting, we can subsequently avoid the need for them to access specialised services like dialysis. If we can identify patients at an earlier stage in their kidney disease, hopefully they won't ever need dialysis, in which case we can reduce the overall cost to the NHS, but more importantly, the patient experience. And we also think that by sort of pooling and delegating budgets at a regional level, that enables any underspend, so any money that's not been spent by the end of the year, to be shared or reinvested within that particular region's within that particular region. So the region can then decide what's best to do with that pot of money next year for their population of patients. Next slide, please. So I mentioned that services are being delegated in these sort of three pots, not the right word, approach, but we'll go with pots. So as I mentioned, there's a number of services. So there's 65 services, and this is across all specialised services. So that's all clinical specialties that we're looking to delegate as of April 2023. Now, from a renal perspective, renal replacement therapy is within that category. So that means these services, including renal replacement therapy, have been identified as a service that are suitable to be delegated to an integrated care board level and are suitable to be led by the integrated care board within each of the regions. Now, just because we've said that we've proposed that they could be delegated, we are working with integrated care boards to ensure that they would be ready to take on these services. And if they're not ready, then we will be working with them to do an iterative approach to delegation. So it's not a blanket everything will be delegated if a region is not ready. There's 27 specialised services that we've said, well, actually, we do think they would be more appropriately and better managed for patients by the Integrated Care Board, but they're just not quite ready to be delegated yet. And there's so many reasons why that might be. But within this category, renal transplant does currently sit. So from a renal transplant perspective, we're saying, yes, absolutely, in the future, we feel it should be ready for greater ICS leadership. But actually, at the moment, we're going to retain the commissioning of that by NHS England, and we'll look to delegate that in the future. And that's primarily because there's a review at the moment called the Organ Utilisation Review, and we're awaiting the outputs of that report to make sure that we delegate that service in line with what's being recommended. And then finally, there's 81 specialised services that will not be delegated to integrated care service level. And they are, in the main, highly specialised services. And what that means is they're services that support a very small cohort of patients in this country who generally have very rare disease. Next slide, please. So that was my commissioning update, and I've tried to keep that quite succinct. I know there was a lot of detail on those slides, apologies for that, but hopefully that just gives you a flavour into what it is a clinical reference group does, what's the point of us here, and the importance of that group, and also why we're doing the changes to commissioning that we're doing. And I think it's really key to say, you know, the changes to commissioning this are happening at the moment are all there to improve access to services for patients and to improve the care for patients. So just to really highlight that today. So now I'd really like to just introduce the Renal Services Transformation Programme and my colleagues. So what is the Renal Services Transformation Programme? And I'm going to shorten it to RSTP because it's very long. So the RSTP is essentially a transformation programme that's being run by NHS England that's looking to transform the delivery of renal services across England. And why are we doing that? We're doing that to support better healthcare outcomes for patients and for service users. What's the impact of this? Why are we doing it? So it's about improving equity of access for renal patients. It's about a better experience for renal patients through the care pathway, reducing waiting times, a smooth transition between paediatric and adult care, and it's about improving care closer to home where that's considered safe. And as I mentioned, commissioning and putting that whole person and whole patient care pathway into one commissioning process is key to all of this as well. Next slide, please. So the RSTP has got 5 work streams: system working, acute kidney injury, transplant, dialysis and chronic kidney disease. And my colleagues are going to give you an insight into some of those today. We're looking at how do we take those work streams and the outputs that they produce, how do we implement those? So we've implemented and we've introduced renal clinical networks across England to implement this transformation to patients, to trusts and across the country. We've got regional teams that are supporting the implementation of this. The integrated care systems will be critical to the implementation of the RSTP outputs. And then we've got the NHS Trust, to whom in NHS England we refer to them as providers of services, but they're basically NHS trusts. And we've listed some outcomes there on this slide for you, but essentially we're producing data dashboards, we're producing toolkits to support hospital teams for best practice. You know, how do they deliver best practice for their patients? And we'll be doing a service specification review. So I touched on service specification earlier. It's one of the roles of a clinical reference group. We're looking at all of the renal service specifications that currently exist. So if you remember, that's the standards of care that we expect NHS Trust to deliver for renal patients. We're looking at how do we improve the current service specifications? Are they fit for purpose? How do we review them and reference our toolkits, our best practice toolkits. So next slide, please. On that note, I will introduce my colleague, Dr. Smeeta. Smeeta.
Hello everyone. So my name's Smeeta. I'm a nephrologist at Salford Royal, and I'm trying to improve the early pathway for patients living with chronic kidney disease. So I'm going to have a go at this slider. There we go. So this is very small, and I'll try and run through it briefly, but this is a made-up case which was produced by NHS Right Care. So it's an organisation with the NHS which tries to show the impact of various different diseases on people individually, on their life, but also on the NHS budget. I'll run through it, but it's a gentleman called Abdul who is 30 years old, had a health check, and it's made up, had a health check done at work, which showed he had some blood and protein in the urine, but it was put down to a urinary tract infection. He felt fine, didn't have any symptoms, so didn't worry about it and didn't make any other appointments with his GP. At the age of 40, he went in for his NHS health check, and he was noted to have slightly high blood pressure, but again, he didn't have any other risk factors. It wasn't too high, so he didn't come back for a repeat test, and he wasn't recalled for a repeat test, and again lost. Several years later, he reattended, and this time with a chest infection, and was diagnosed with acute kidney injury. So that's when the kidney function has declined suddenly because of something else happening. And again, he got better, but his general health started to decline, and then a few years later he was admitted to A&E and diagnosed with CKD, but at the point where he needed to start dialysis. The rest of the slide talks about the complications that he experienced, and you'll have heard of people having complications from a heart and cardiovascular point of view, the challenges with access to transplantation and a waiting list, and that sometimes if you wait too long, that can still cause problems down the line. So what this case did showed a really strong narrative about the importance of managing CKD earlier and identifying it earlier, so we've got more chances to make an improvement. And it's really important for us, not just at an individual level, but at a population level. So this is data from an audit that was done 5 years ago now called a CKD audit. And what it showed is that there is quite a lot of prevalence around the variation in prevalence around the country, anywhere from 3% up to 9%. But you can see on the map of England there, different areas have different prevalence. Our population is aging, so just like our joints age, our organs age, so we see more kidney disease as you get older, so we're going to see more of it. Our population is perhaps not as healthy as it used to be, so we're more likely to see people with diabetes, and diabetes is a really common cause of kidney disease. We're really lucky in renal medicine, though. We've got two really simple tests that can help us diagnose patients, and I'm going to say two because we have always historically focused on the blood test, the eGFR, but possibly even more important is the urine test, because that tells you there's a problem before your GFR actually falls, so before the blood test gets worse. So if we look at this, you can see we're not too shoddy at doing the blood tests, but we're absolutely terrible at doing the urine test. So there's a massive missed opportunity to find people before their kidney function actually gets worse. So this is why the CKD workstream was really keen to look at things downstream. How can we actually do the beginning bit? How do we get people diagnosed early, and how can we get them using the test that diagnoses early? And that's the urine ACR, and that stands for urine albumin creatinine ratio. And what that test does is it measures whether the kidneys or the filters are leaky. And if they're leaky, that's an early sign of damage, and you'll see them leaking protein in the urine. Eventually, they continue to be leaky, but then they also get scarred, and that's when the kidney function drops. So looking for leaky kidneys is a really good chance to diagnose people early. And the good thing that's happening now, and hopefully will continue to happen, is that we're now finally getting some drugs and some therapies that can slow down how quickly your kidney function declines. So there is a point to doing all these tests early now, because we can do something about it. So I'm going to show 3 slides about what the CKD workstream has focused on. And just as Lydia mentioned early, the CKD work stream is like the other work streams, has representation from our patients, our carers, not just doctors, but also GPs and our allied healthcare professionals. So we've got, this slide is the first one, which looks about sort of a model of delivery. So how can we deliver care as an outpatient, and how can we find people virtually? Most of you know that you sadly only tend to see a nephrologist when your kidney disease is already established. So how can we provide that advice and guidance earlier on? So there was a virtual CKD conference which was delivered by the UK Kidney Association almost a year ago, where we wanted to learn about what was happening around the country before we started developing our recommendations for the ICSs and ICBs that Lydia talked about. We wanted to provide some guidance to primary care, so GPs, so that they knew how to manage patients early on before the point where they get to referral. So we've issued some guidance to the primary care and to the ICBs. And we also wanted to make sure that medicines were optimised and that we were sort of up to date, making sure that we have some digital approaches. Oh. My slide stopped. There we go. The other area we wanted to focus on in CKD was transition. Again, Hattie referenced this because she went through transition. She went from paediatrics to adults. And we know that this is an area where things can sometimes go wrong. And we also wanted to use it as an opportunity to try and understand, we call it the biopsychosocial model of care, but that's life. So the impact of life on the impact of a kidney disease on people's lives. So our transition group worked with the paediatric group, looking at how we could start the transition process at a time that worked for the individual. And we also wanted to make sure that their psychological well-being was monitored and then something was being done about it. So there are some tools that they've recommended in there, including as well as access to psychology. And then the social element is how can we support outside kidney disease? You know, people have education, they have jobs that they want to do. So access to youth workers and peer support. Again, Hattie's described this far better than I can. And also some national networks that they can get involved with. So we'll be producing a toolkit that we will share to integrated boards and those providers, those hospitals, to make sure that they provide access to those things for their patients who are transitioning from paediatric to adult care. And then the other area we identified as needing extra sort of transformation or support was supportive care. And this was a key part of a document produced by this group called GIRFT. So GIRFT stands for Getting It Right First Time. And what they try and do is go into different services to try and find out what changes need to be made to make sure that patients' care down the line is good. And they also identified that supportive care was an area for need. So what is that? So supportive care is, there are two types of supportive care. One is when people choose not to have things like dialysis or a kidney transplant, and they want to be able to live as well as possible for as long as their own kidneys allow them to do so. So that is what we've traditionally called conservative care. And then there are those people who are on renal replacement therapy. So they may be on dialysis and have a transplant, but perhaps things aren't going as well. And they're wondering whether they want to plan for the future in a more coordinated way that respects their wishes and what they want out for their lives and their families. So we developed a supportive care group, which is led by a specialist nurse called Karen Jenkins, or she's a nurse consultant, called Karen Jenkins, and her team is made up of people from palliative care, the community, and again, patients and carers. So they're developing some recommendations to make sure that everybody has access to good supportive care, regardless of where they are in the country. And the last thing, which is stuck at the bottom, is but is actually probably the most important one from a long-term perspective, is we want to make sure that a focus on quality improvement is embedded into one of these major clinics called the Advanced Kidney Care Clinic, because that's where most people whose kidney function is declining will go at some point. So there's a good opportunity there to make sure that we're ensuring patients have access to evidence-based stuff like early transplantation, home therapies and choice. So we've asked for that to be a core part of advanced kidney care clinics around the country. So that gives you a very brief run through of what we've been doing from the CKD workstream perspective. And I think in the interest of time, we're going to take questions at the end. So I will pass on to my colleague, Dr. Albert Power.
Thank you very much. Thanks, Smeeta. So I'm Albert Power. I'm a kidney doctor in Bristol, and I lead the dialysis workstream. And what I'm going to try to do is just run through, focusing mainly on the key component of what we're doing in the dialysis workstream, but also talking to you about broadly what we're looking to achieve. My clicker thing isn't working, so if you just please move it on a slide, that'd be great. Thank you. Well, I think we'll just sit back first of all and just have a look at what the national trends are. We talk about renal replacement therapy. It's essentially treatment for people who have kidney failure. The optimal treatment is transplantation, and you'll see there on the graph on the left that the number of people being treated with all forms of renal replacement therapy is increasing year on year. And I would say, thankfully, this is driven predominantly by ongoing transplantation. And Nick will talk to us about the work of the transplant work stream next. If we look at the people who are treated by dialysis as opposed to transplant, we can see on the left that patients on dialysis are typically older, and actually as we move year on year, this population is aging. So there are different needs and requirements of people on dialysis, I would argue, as compared to people with a functioning transplant who on the whole, you can see there on the dark red line, are on average younger. Next slide, please. So what is the case for change for dialysis services? Why can't we just leave things as they are and continue plodding on? And Lydia's spoken in part about some of the policy changes, the introduction of integrated care systems and the NHS long-term plan. And I probably, in my simplistic doctory mind, would just envisage this really as an attempt to try to bring all strands of care into one system to avoid disruption and ensure quality. And you could argue that dialysis has rather stuck out itself on its own, a specialist service delivered by specialist units with a lot of fragmentation around elements of care. So I think we need to move with the times and see how we can improve dialysis delivery to get the most out of these new structures. And as an overarching vision for this transition is the importance to move with ongoing improvements in the quality of care that we deliver, not just the clinical quality, blood test markers, blood pressures, that sort of thing, but also patient experience of care as a key quality of marker in dialysis, improving equity of access to all forms of dialysis therapy, and I'll focus a lot on home dialysis treatments, and how we can improve value to the healthcare system as a whole so that, for example, all the money that we pay in taxes actually delivers the best benefit for patients in the long term. Next slide, please. So what about home therapies? Why the focus? Oops, sorry, that was my watch. So why the focus on home dialysis therapies? Well, we recognize that there are multiple benefits to patients treated with this form of dialysis. It's a flexible treatment that can be delivered around people's lifestyle, their weekly schedule, rather than the other way round that tends to happen with in-center hemodialysis, where actually people need to tailor their life around their dialysis treatments. In so doing, home dialysis treatments can increase autonomy, facilitate travel, both within the UK and abroad, and arguably lead to a completely different patient experience of treatment. And also because one can change the time as well as the impact of dialysis therapy on general well-being, as Simon described earlier, this sort of drained feeling, the time to recovery you get with hemodialysis. This is minimal to negligible in home treatments. It can enable people to continue in employment. But there are also benefits to the healthcare system. Of course, there's a reduced cost. Dialysis units are expensive. They're expensive to run, they're expensive to maintain, not just in terms of building, but the staffing costs associated with them, as well as the transport cost associated with taking people to and from their dialysis treatment 3 times a week. Arguably, there's a benefit in terms of medication costs. On average, people who are treated with home dialysis therapies tend to have a lower requirement for blood pressure lowering medicines, treatments for their anemia, and the dreaded phosphate binders, sort of multiple dosing regimen to try and lower dietary phosphate. And of course, because of the knock-on effects of keeping people in employment, leading fulfilling lives, you could argue that actually this is a beneficial state for GB plc as a whole. So if this is so great, why are we seeing this degree of variability there on the right? So this is a graph that was published in the Renal Getting It Right First Time report. Smeeta already mentioned GIRFT. And you see there the variability in uptake from centre to centre across the UK of home dialysis treatments, be it peritoneal dialysis, PD, or home hemodialysis, HHD. And great variability seen there from centre to centre. Next slide, please. So we see variability in terms of uptake. And we're also very sensitive within the work stream to whether access to home dialysis therapies is equitable. And there's been some work done by the equity team within RSTP looking at home dialysis. And these are just some of the outputs. You'll see there PD rates and home therapy rates as a whole, really showing that there is a correlation between social deprivation and the uptake of home therapies. And this is a really important data metric to be able to feed back to kidney networks, integrated care systems, and say, well, what are you doing to try to address this variability that we see there? The aim of RSTP was framed by the GIRFT report, recommending that all networks, all providers are able to deliver home therapies to a minimum of 20% of all their dialysis patients. And that remains a key tenet of the home therapies subgroup within RSTP. Next slide, please. I've spoken about home therapies. That isn't the only focus of the dialysis work stream. We are looking at how we can deliver safer and durable dialysis, be it hemodialysis or peritoneal dialysis, with a key focus on access, on dialysis access, be it for hemodialysis in terms of promoting fistulas as opposed to dialysis catheters, and reducing access-related infections on hemodialysis, as well as an equivalent in PD. In other words, being able to access prompt PD catheter placement and reducing the impact that PD catheter displacement and infection can have on being able to stay on peritoneal dialysis. And the outputs of the work stream comprise of exactly what Lydia outlined. So a set of toolkits, revised service specifications to support the above, as well as data metrics to support providers and networks in ensuring that quality is maintained and improved over time. And in parallel with this, you can see that there is a separate group working through all the work streams, looking at being able to identify health inequalities and provide tools and metrics to drive change where inequity is demonstrated within our services, as well as improving the psychosocial health of patients being treated with all forms of kidney therapy. Next slide, please. So what would be the potential benefits that we would expect to see through this process in the dialysis work stream? Well, I would argue that the real aim here is to try to improve the quality of the dialysis that is delivered, but also improve quality of life for people and access to treatments that they would want to receive based on clinical advice, but really their own choice, an informed choice. And Smeeta already mentioned the importance of that, if you like, the pre-dialysis section of the patient journey, the advanced kidney care clinic, and being able to make those informed choices that fit with people's lifestyle so they get a better experience of care. Stepping back on a wider system level, the benefits would be to allow better use of resources, managing capacity so that that doesn't impact on patient care and experience, and being able to then drive change at a system level to iron out health inequalities and continue to improve the services that we have available for patients. If you could just press again on the next slide, please. Because that would be the end state that I would envisage for the dialysis work stream, that home therapy options are effectively communicated ideally early to people, and particularly to people whose kidney function is declining and for whom preemptive transplantation or indeed a conservative approach is not appropriate. So driving to achieve that minimum of 20% and keep going on beyond that mark as appropriate. To measure and address inequity of access in dialysis therapy provision, and to have the tools to allow decision makers and commissioners to be able to make the changes that are necessary to ensure that we're doing the best that we can. Thank you. Next slide, please. That's right. And I'll hand over to Nick now.
Great, thanks, Bert and everybody. My name's Nick Torpey. I'm a transplant nephrologist at Addenbrooke's Hospital in Cambridge, and my first slide here, actually Hattie has put all of this far more eloquently than I can. As Bert has said, for many patients, transplantation is the optimal treatment for end-stage renal disease. And in the box on the left there are just some of the benefits derived from transplantation. As I say, Hattie has articulated that better than I can. I guess there are 2 points I would make. The first, that the graph on the right, which relates to the USA in the 1990s, so it's not contemporary, documents rather depressingly the risk of death for people in the general population, those with a transplant and those on dialysis. So if you're a 50 plus person like me, the bottom blue line it represents your risk of dying each year in the general population. It's about 1 in 1,000. The top line represents that risk should I be on dialysis, and that's close to 1 in 10, a very alarming difference. And the black line in the middle is the effect of transplantation. So your survival, your risk of death, the risk of death is reduced substantially, and therefore your survival enhanced. So transplantation has this one fundamental benefit for many patients compared to dialysis. The other really important point is transplantation is fantastically cheap compared to dialysis. So a year with a functioning kidney transplant is a fraction of the cost of a year of dialysis. So bearing all that in mind, the next slide is very encouraging. This is the number of people that have received a kidney transplant each year in the UK leading up to the COVID pandemic. And the white bars at the top are living donor kidney transplants, and the grey and the blue bar, which you need to add together, they're the number of people that have received a deceased donor transplant. And in 2007, there was a very important event. There was something called the Organ Task Force was established, which was chaired by Dame Elizabeth Buggins, who I think many listening will be familiar with. And that produced a report, Organs for Transplantation. And the challenge in that report was to double the number of deceased donor organs over the next 10 years. So the first year after that report was in 2009, and there were 1,400 deceased donor kidney transplants. Expressed 10 years to pre-COVID, well, we've almost achieved that ask. There were more than 2,400 deceased donor transplants, and the sustained increase in deceased donor transplantation has been hardwired, if you like, by further strategy documents from NHS Blood and Transplant. And the really encouraging endpoint of all of this is that if you were waiting for a kidney transplant in 2010, the average wait was more than 3 years. If you're waiting for a deceased donor kidney transplant now in the UK, the average waiting time is less than 2 years. In fact, it's 570 days. So the waiting time has more than halved. There have been other important developments as well. Oh yes. So in 2019, the way that kidneys were allocated was changed to improve equity, and I'm going to come back to that point. The following year, in 2020, the law changed to promote to create the opt-out system for donation, which you heard about earlier. And then during the COVID pandemic, there were two important documents. The first is the GIRFT report that you've heard, and the second is the updated NHS blood and transplant strategy through to 2030. Both of those documents emphasized both the tremendous achievements over the last 10 or 15 years, but also that we shouldn't be complacent. And on the right there is a sort of table elaborating the ambition of the 2030 strategy. And everything I've talked about up to now is on the left-hand side, the donation side. On the right-hand side, the transplantation side, there are clearly areas that we need to improve, and they were highlighted very much by the GIRFT report. And I'm going to give you just 3 examples. So the first is that depending where you live in the country, the probability that you would be assessed and listed for a kidney transplant before you need dialysis is very variable. So in some parts of the country, it may be only 10 or 11% of patients are preemptively listed. In other parts, up to 50%. The second example is that although waiting times have improved enormously, there is still variation. So the best is the wrong word. The centres with the shortest waiting time have an average waiting time from listing to transplant of maybe 300 days, and the longest waiting time 700 days. So that's a vast improvement from the past, but there's still variation. And the third thing is that patients from either Black or Asian ethnic backgrounds, we know are much more likely to develop kidney disease, but their access to transplantation is less. So it takes longer to be listed. When you are listed, you're less likely to be offered a transplant. The thing on the left is I guess, documenting all of those things in the RSTP format that you've heard about already that I won't talk about. And from those 3 examples I've given, I think you can see that the key focus of the transplantation bit of the RSTP is on the first bit of the pathway. So identifying, assessing and waitlisting patients in an equitable fashion, preferably before you start dialysis, so that everyone has an equal opportunity to be offered a kidney. And that was very much emphasized by the GIRFT document, and the three key highlights are listed there on the right. I'd include a fourth, which is that all of these activities need to be properly commissioned. So that is to say, the people delivering the care are funded to deliver the care. So in the RSTP transplant program, we have groups working on all the 4 things listed on the left there. So as I've talked about already, assessment for deceased and living donor transplantation, management on the waiting list. Then there's the whole business of receiving a transplant in a hospital and follow-up. So we've identified the things we need to focus on. We've identified how we need to focus on them. That's the service specification that you've already heard about. And the challenge now is, how do you embed that into clinical practice? So how do you commission services to deliver all of these improvements? And Lydia's touched on the fact that the way we deliver services is changing, and transplantation in particular is challenged by quite significant changes that are happening in NHS commissioning. So I'm going to stop there. I think I'm going to hand back to Lydia to sum up.
Thanks, Nick. Thanks to all my colleagues. So in terms of what to expect next, sorry, if you could just go back a slide. Still having trouble with my clicker.
That wasn't me.
Oh, to the 2023 slide. Thank you. Thanks very much. So in terms of what to expect next, so we are anticipating that we'll see the following being rolled out in 2023. So we'll have the updated service specifications. So we've mentioned those on several occasions through the presentation. That'll outline the best practice that are being produced by my clinical colleagues across their work streams. We will have the Renal Services Clinical Reference Group, and we will have a new Renal National Clinical Director, a really exciting post for renal services in England that's just been reintroduced. And that new Renal Services National Clinical Director will manage both the clinical reference group and also provide clinical leadership for the Renal Transformation Services programme. So that role will pull all of this together, which will be critical to delivery of the transformation programme in the future. We'll have regional accountable networks, and as I mentioned, we've established renal networks across England, and their primary focus is to deliver the outputs of the Renal Transformation Services programme. They've got high impact changes that they're working towards delivering across all of the regions in England that focus on quality improvement initiatives. And finally, we'll have the toolkits and the renal dashboard that detail quality and patient experience metrics to support decision making. So there's so much coming out of the programme, and we anticipate it really will improve renal patient care of the future. Thank you very much.
Oh, thank you very much. Thank you. Very interesting talk, and great to hear improvements coming our way. A couple of questions before we go to the break. Are the toolkits in the public domain?
I'll look to my colleagues for some support, but I'll take that question. So the toolkits at the moment are still in development. So we're anticipating they will be available, as we say, in 2023. The toolkits will form part of the overall service specification, and all NHS England service specifications are available in the public domain on our web pages.
Right, another question. How will you deal with the services which cut across more than one ICS but are not national?
So really great question, thank you. So as I mentioned, at the moment, we are NHS England have a number of groups that have been established to look at how we can best support integrated care services to manage the care pathways. But what integrated care services will do is work together to make sure that if there are crossover of care or services that involve multiple ICS platforms, they will work together to ensure that there's seamless access to care for patients, and that will be the expectation of NHS England.
Another question, this would be interesting. Is there any consideration for introducing bio-artificial kidneys into the NHS?
Shall I? I guess you mean
Please.
As an alternative to a kidney transplant. So bioengineering organs for transplantation is very challenging. Probably the most advanced the area that's most advanced is heart transplantation, because the heart is basically just a muscle with some electrical wiring going into it, and so that's quite easy to regenerate. The kidney, unfortunately, is spectacularly complicated. There are lots of different cell types that make up the kidney, all of which need to interact together. So I think the probability that we will be able to bioengineer a functioning kidney for transplantation in our lifetime is negligible. I think the area that is likely to attract much more attention is xenotransplantation, and some of you may have seen some sort of headline events in the USA where pig kidneys have been transplanted, and in fact a pig heart into people, and that's something perhaps to watch out for in the next 10 or 20 years.
Brilliant, thank you. Ladies and gentlemen, thank you very much for that very interesting talk. Everyone wants to put the kettles on, so we're going to take a break now for 10 minutes. When we come back, we're going to be looking at dialysis decision making. So let's look at our watches. We'll come back at 12 o'clock. If you leave your feeds on, we'll just return in a little while. Thank you.
Thank you.